Today I'm going to discuss what I do, how I do it, and why I do it. The procedure is not appropriate for everyone, and I'll freely discuss its limitations. I want to discuss the evolution of surgical thought and suggest to you that ACL repair was inappropriately abandoned back in the 90s. Before I continue, however, I want to pay deference to some of the giants of this discussion, pictured here, including Colonel John Fagan, who passed in the past year or so. It's their work and ideas that we're building on, really. The theory as to why the ACL repair doesn't work is that unlike the MCL, which holds the reparative clot, for the ACL, the clot does not stick due to the aqueous environment in the knee, and therefore the torn ends of the ACL are unable to coalesce. But we all know that some ACLs do heal on their own. And we also know that the ACL sometimes scars to the PCL. This study looked at the biopsies taken where the ACL had scarred to the PCL and showed very similar histology to the healing MCL, suggesting that perhaps the proximal end of the ligament heals more readily. Certainly, we know the proximal end has better blood supply. In fact, this systematic review of the old literature bears this out. When the old papers were segregated based on tear type, the outcomes were significantly better in all categories if there was a proximal tear, as seen in red. This was one of my first papers that my group published to open the dialogue about revisiting repair. We suggested that it is not that the ACL can't heal, it's just that only certain types of ACL tears can heal. And by looking at the failures rather than the successes, we historically saw the glass as half empty and threw the proverbial baby out with the bathwater. This resulted in a wrong turn in the evolution of ACL surgery that led to extinction of the idea that the ACL can heal. Which brings me to this slide that I love to include because it reminds me that as a resident, I and everyone else was taught that the ACL cannot heal because it has poor blood supply. But it's readily apparent that this proximally torn ACL seems to have excellent blood supply, as you can see by the robust capillary refill. I've learned that this is the perfect tear to perform a repair on, and in this patient we did just that, using my internally braced suture anchor repair. At 1 year, during a follow-up scope for a meniscus tear, you can plainly see that the ACL is healed up nicely with excellent scarring back to the origin at the femur. If you look closely, you can also see the internal brace under the scar tissue. This looks like it's getting a little chunky. Sorry about that. There's the internal brace under the scar tissue there. So briefly, there are four main techniques out there for modern day selective ACL repair, all of which use some sort of augmentation. On the upper left is my suture anchor approach, to which I added the internal brace very early on. On the upper right is the transosseous internal brace approach described by McKay and studied by DeWeege and Wilson. On the lower left is the dynamic intraligamentary stabilization, or ligamus technique, which anchors their augment stitch to a rather large spring that is buried in the tibia so that the system has some give. And finally, on the lower right is Martha Murray's bear technique, which is more focused on mid-substance tears and stitches a blood-soaked collagen sponge between the ends of the ligament. This idea of repairing the ACL seems to have struck a chord with surgeons. There have been no less than 10 reviews on the topic of ACL repair of late. I only have time to review one. My research group focused in specifically on modern, selective, arthroscopic ACL primary repair techniques, and we reviewed 13 studies encompassing 1,100 patients. We divided the techniques into non-augmented, static augmented, including the internal brace techniques, and dynamic augmented, including the ligamus data. There were no significant differences in patient-reported outcomes between the different groups, with all scores over 85, and we concluded that the outcomes were promising, but that higher levels of evidence were needed going forward, as is typical with most new techniques. Taking a closer look at the data, we can see that failure rates across all techniques averaged 11%, with no significant differences between techniques. Also note that the dynamic augmented group had by far the most patients, although this is changing as we have another review submitted with over 400 patients just in the straight repair groups. But what we did notice was that there was a significant difference between techniques when we looked at reoperations and removal of hardwares. And here the ligaments technique had nearly 40% of their patients have a second operation, the majority of which was to remove the spring from the tibia. My approach I call ACL preservation. It's focused on my belief that the complete ACL tear on the right has a better chance of healing than the complete ACL tear on the left. And that using my internally braced suture anchor technique to repair it is one of several methods that appear to be safe and reasonably effective in achieving this goal. It's my opinion that an all reconstruction approach to ACL surgery is inappropriate. Let's look closely at my technique. There's tremendous benefits to the suture anchor ACL repair approach. The first and foremost is that it is simple, intuitive, and it works. It's anatomic, it preserves biology, it's minimally invasive, there's no need to take grafts, it's easily expandable to include the internal brace, and if it happens to fail, it's quite easily converted to a reconstruction. My approach to ACL surgery is what I call ACL preservation. It's a published treatment algorithm that is based on tear type and tissue quality. I evaluate the remnants and possibility of repair by meticulously scrutinizing the MRI. We've published classification systems, a modification of Sherman's in both adults and children, and I tend to focus my repair efforts on types 1 and 2 tears situated in the proximal 25% of the ligament. If I have an excellent remnant, I'll perform an internally braced primary repair based on using my suture anchor technique. If the remnant isn't robust enough to afford a repair, then I will repair what I can and add an augment to that. And finally, if there's little good tissue to salvage, then I will proceed with the reconstruction. In my practice currently, I repair 50% of my patients, all comers. I augment 25%, and I only do reconstruction in 25%. Last year, we published this paper looking back at 361 ACLs that I had performed. I was able to repair 158 of these patients, 44% of that group. And when we did a multivariate regression analysis, it turned out that age over 35, surgery within a month of injury, and BMI less than 26 were all predictive of having a repair. And I would add that although the likelihood of getting a repair is much better if I get you to the OR within 4 weeks, it's not impossible if the patients present to me at a later time frame. In fact, I have over 100 patients whom I've successfully repaired anywhere from 3 months to 11 years after the injury. This is how I do it. This is a quick slide I've sped up. So here we are assessing the tear. This is a type 1 proximal tear. We're going to pass a locking Bonnell stitch up the anteromedial bundle of number 2. This is a fiber wire. And then we're going to repeat that first we're going to park those sutures out in inferomedial portal, and we're going to repeat that with a tiger wire up the PL bundle, as you can see here. In order to get the PL anchor at the right spot, we flex the knee up to 115 degrees. We drill, tap, and then place our 4.75 biocomposite anchor. We're going to repeat that with the knee at 90 degrees for the AM bundle, although this anchor is going to have an internal brace or fiber tape attached to it. Then we're going to drill up with standard ACL tibial guide up into the anterior third of the ACL, allowing us to pass a wire and retrieve the fiber tape to create our internal brace. With the knee in full extension, this is then anchored down to the tibia with the final anchor. We can check for range of motion, impingement, and you'll see here we have a nice stable lockment. We have multiple publications as to my results that I want to share with you, but given the time limitation, I'll only share the most recent, which I think is a critically important one. We recently published on the first 113 patients with a minimum of 2-year follow-up. We had 100% follow-up in all of these patients, which is nice. This is the first paper to break down the failure rates by age groups, and the findings are very important. The over 35 age group, which is by far the majority of the patients, had a 3% failure. The 22 to 35-year-old age group had a 4% failure, whereas the under 21 group had a 37% failure rate, which was rather disappointing, as you can imagine. These findings have led me to adjust my indications in my youngest athletes, where I'm much more likely to place an augmentation graft with the repair nowadays. Failures in this age group are also rather high for reconstructions, and I personally believe that the issues are multifactorial. Nonetheless, I recommend caution and tight indications in this age group if you choose to add ACL repair to your surgical armamentarium. Overall, I've performed close to 400 primary repairs at this point, far more if you include multi-legs, mostly on types of 1 and 2 tears. I've been using the internal brace with all of my repairs for close to 5 years now. And overall, I'm running at about a 10% failure rate. And as I mentioned, it's higher in the under 21-year-old age group. I repair approximately 50% of my ACLs, and in the over 35-year-old cohort, I repair 85% of these patients. Regarding return to sport with ACL repair, we published on a group of 60 patients with 2-year follow-up, and our numbers were very similar to our return to sport after reconstruction, although recovery times were much faster. We also published on the difference in awareness of the knee between repair patients and reconstruction patients, and showed that repair patients think about their operative knee far less than reconstruction patients. It's a very accurate metric for overall satisfaction. So the goal of the research is to make other surgeons aware that certain types of ACL tears can heal with a modern approach with a significantly easier recovery, and we're trying to make things better. I think that your toolbox should be chock full of choices as to how to restore stability to the knee, including the ALL and the ramp, as previous speakers mentioned. I believe that ACL proximal tears should be looked at as low-hanging fruit on the ACL injury tree, and this is a low-risk, high-reward surgery. And lastly, I can tell you one time when you're never going to try a repair, and that's when you have a graft in your hand. And we've all taken the graft before and then looked in the knee to see what appears to be an intact ACL. And perhaps it's a proximal tear, or it's just loose, but we resect it. So one of the first things you can do if you're interested in this research is to change your workflow. Study the MRI, then scope the knee before taking the graft. This will allow you to better appreciate the patterns of tears. You can practice the technique and work up to it and go from there. There's quite a number of resources out there for you to familiarize yourself with this technique, including a kit that's sold by Arthrex, whom I'm a consultant for, that's designed and has all of the things you'd need to accomplish the surgery. Finally, and most importantly, I want to thank my research team for doing yeoman's work in helping to publish over 50 papers in the ligament repair space in the past 5 years. Jelle van der List just got his PhD and actually just won the PhD award. I think it was from the British Medical Journal for his work. Thanks for your time and attention.